Good morning, everyone. We'll be discussing about endocrine disorders of pregnancy, which are quite common. So, we'll be covering thyroid as well as diabetes. So, as we all know, there are some changes that happen during pregnancy, normal changes that happen during pregnancy in thyroid metabolism. The iodine clearance goes up because of the transplacental and renal increased clearance. And because of that, there is a relative iodine deficiency, which increases the requirement of iodine during pregnancy. There is deiodination of T4 by the placenta. In normal ladies who have a normal thyroid function, the thyroid takes care of this increased demand, but those who are hypothyroid need to be increased. There is a requirement of increased dose for them. There is an increase in the TBG because of increased estrogen, and that leads to an increase in total T3 and T4 concentrations, but the free T3 and free T4 remain stable. Again, because of the HCG in first trimester, HCG resembles TSH in structure. So it stimulates the thyroid gland to produce more T3 and T4, and the TSH decreases. If someone has had Graves' disease, it might go into remission because the TSH receptor antibodies are reduced, but they might have a postpartum flare later on. So a lot of you might be encountering this case during pregnancy. Someone who comes in first trimester routine screening, you find that the TSH is elevated, very elevated. TSH of 35, free T4 slightly low. So they now want to know whether they can continue the pregnancy and what are the risks associated. Any level of hypothyroidism, even overt hypothyroidism, is not an indication for MTP. So we definitely tell them the pros and cons, but we don't ask for MTP for even overt hypothyroidism, because once we treat this condition, which is very easily treated, the risks are almost negligible. Even the neurodevelopmental problems that a lot of these patients are concerned of, once we start treating with levothyroxine, they are almost negligible because the brain develops till 2 years of age. So we have a lot of scope there to let the brain development happen normally once we substitute levothyroxine for these. So what do we test? We look at TSH. Ideally, there should be trimester and area-specific ranges, which we don't really have here. So what we usually take as the upper limit of normal is 4 milliunit per liter for TSH. Apart from TSH, what do we test, total or free? There is differing recommendation for this. The American Thyroid Association says that total T4 is a more accurate test, but you have to adjust it with pregnancy. As I told, that TBG increases, so total hormone goes up. So after 7 weeks, a 5% increase can be taken, or simply in second trimester, we can multiply it by 1.5 times the upper limit to get the normal total T4 value. The British guidelines say that prefer free T4, but again, free T4 might have some inaccuracies in pregnancy when we measure it. What can we do? Probably at the first time we can do both and then try to interpret it later as we go on. Per se, the European and American associations don't recommend a universal screening, but there a lot of cost-benefit discussions come into play. I think for most of us, most of our patients can afford a simple thyroid function test, and my professional opinion is definitely all pregnant ladies should be screened. So consequences of untreated overt hypothyroidism in pregnancy include preeclampsia, abruption, increased miscarriage, operative delivery and postpartum hemorrhage, and the baby can have preterm delivery, increased perinatal morbidity, mortality, and neuropsychological cognitive impairment, but this is when it is left untreated. Mostly when we treat, the outcomes are extremely good. So how do we manage hypothyroidism? All the agencies have a consensus that any TSH above 10 should be treated. There is no doubt about it. Most of the agencies also agree that a TSH between 4 to 10, that is subclinical hypothyroidism, should be treated. So where the controversy comes is when we have a pregnant lady with a TSH between 2.5 to 4. The British guidelines, RCOG, say that don't treat such patients, but the ATA, American Thyroid Association, says that especially if someone has had a bad obstetric history, if someone has had recurrent miscarriages earlier, there are some studies that show that if the patient is TPO positive between a TSH of 2.5 to 4, there are benefits. Some studies show that there are no benefits, but per se levothyroxine is harmless at a very low dose. 25 to 50 microgram is very harmless. So we might as well give the benefit to some patients who get it. Definitely a TSH 2.5 to 4 with TPO negative should not be treated. So above 4, all women should be treated. 2.5 to 4, TPO positive, especially with a bad obstetric history, should be considered treatment. So when we start a patient on levothyroxine replacement, we target a TSH below 2.5. Now, if someone is already a hypothyroid patient, we tell them that they can, the requirement, as I told, increases during pregnancy. So what they can do is they can take 2 additional doses. It increases by 30%. So suppose they are taking 50 microgram per day, we can tell them to take 2 additional 50 micrograms on Saturday and Sunday. So that way it makes up for that 30%. We monitor them every 4 to 6 weeks till 20 weeks, and then at 28 and 32 weeks.